Good morning and welcome everybody. Today I am starting the remaining portions of the anterior mediastinal mass. Preoperative considerations. History should include the questions about the following symptoms. Supine dyspnea or cough suggests the possibility of airway compression on induction of anesthesia. Supine syncope suggests the vascular compression. Identify the patient positions that exacerbate and ameliorate the symptoms, bearing in mind that it may be more difficult to ascertain symptoms in pediatric or elderly patients. Evaluation. By chest X-ray, most important pre-op test is CT chest or trachea. A cross-sectional tracheal area less than 50% of normal predicts the frequent perioperative respiratory complications with general anesthesia. Fiber optic bronchoscopy may be helpful to assess the airways and potentiate the potential dynamic compressibility. Pulmonary function tests may be helpful in determining the degree of airway compression. Determines the flow volume curves in the recumbent and sitting positions. A decrease in the flow or plateau during expiratory phase suggests intrathoracic obstruction. Maximum expiratory flow 50 over maximum inspiratory flow 50 is one of the most useful parameter of the pulmonary function test. Maximum expiratory flow 50 is the maximum expiratory flow, that is MEF, at 50% vital capacity. Maximum inspiratory flow 50 is the maximum inspiratory flow at 50% vital capacity. Maximum expiratory flow 50 over maximum inspiratory flow 50 less than 1 is concerning for intrathoracic obstruction. ECG. If the CT or clinical examination suggests hemodynamic compromise, transthoracic or transesophageal echocardiography, it was on echocardiogram. Echocardiography is indicated and should be performed in the recumbent and lateral positions to assess for compression and changes in the feeling. Consider the preoperative irradiation or chemotherapy to decrease the tumor mass and decrease the perioperative complications. Labs to consider. CBC should be obtained to estimate the allowable blood loss and evaluate for associated thrombocytopenia. Type and cross. ABG if respiratory symptoms. Intra-op management, pre-induction. Adequate personnel should be available prior to induction, including surgeons prepared for immediate rigid bronchoscopy, a second anesthesiologist and nurses. Perfusionists should be present for high-risk patients. Minimize the preoperative sedation, which may produce respiratory depression or muscle relaxation. Ensure the adequate IV access. In patients with SVC syndrome, large bore lower extremity access will likely be most effective. Pulse oximeter or arterial line should be placed on the right upper extremity to monitor for perfusion of brachiocephalic trunk. In patients classified as uncertain or unsafe, central venous access and arterial line should be placed prior to induction. Consider the airway backup plans, including various tube sizes, reinforced tubes, flexible fiber optic scope, rigid bronchoscope for unsafe patients, primary bypass circuit and perfusionists. Induction. Optimal positioning. Consider the tumor location based on the imaging and document the patient's position of comfort. Induction should be performed in the position of greatest comfort. Number 2, the transport to and from the operating room should be done in the patient's position of comfort. Number 3, patients with evidence of SVC syndrome should be transported with the upper body elevated, that is semi-fowler position. Induction should be performed in a stepwise manner with continuous respiratory and hemodynamic monitoring and maintenance of spontaneous ventilation. Short-acting medications are preferable. Sevoflurane is preferred for inhalation induction. Etomidate is an ideal for IV induction due to short duration of action, maintenance of muscle tone, maintenance of spontaneous breathing, and minimal effect on hemodynamics. Remifentanil is a good opiate choice due to its very short half-life. Avoid the use of muscle relaxants due to risk of worsening airway compression. If the procedure necessitates muscle relaxation, attempt a trial of mask ventilation first. Short-acting medications are preferable. Sevoflurane is preferred for inhalation induction. Etomidate is ideal for IV induction due to short duration of action, maintenance of muscle tone, maintenance of spontaneous breathing, and minimal effect on the hemodynamics. Remifentanil is a good opiate choice due to its very short half-life. Avoid the use of muscle relaxants due to risk of worsening of the airway compression. If the procedure necessitates muscle relaxants, attempt a trial of mask ventilation first. As anesthetic depth is slowly increased, begin to assist the patient with respirations incrementally. Small doses of succinylcholine injected slowly may be considered during this trial. If airway pressures are not significantly changed, you can cautiously proceed with muscle relaxation and mechanical ventilation. Potential intra-op complications. Problems with oxygenation may be due to airway compression. Maneuvers to relieve the compression include reposition the patient, recalling positions of the comfort from preoperative evaluation. Confirm the ETT position with fiber optic bronchoscope. Confirm the ETT position with fiber optic bronchoscope. Now advance the ETT past any obstruction under visualization with bronchoscope if possible. Rigid bronchoscopy may be effective to ventilate past the point of obstruction. Return to spontaneous ventilation. Potential intraoperative complications. Problems with oxygenation may be due to airway compression. Maneuvers to relieve the compression include reposition the patient, recalling positions of comfort from the preoperative evaluation. Confirm the ETT position with fiber optic bronchoscope. Hemodynamic complications may be related to mass compression of the heart and great vessels and include the severe hypotension, arrhythmias and cardiac arrest. Consider the following treatments. Volume resuscitation, evaluate for surgical bleeding, evaluate for tension pneumothorax, prompt surgical decompression via sternotomy for severe cases, cardiopulmonary bypass for severe refractory hemodynamic instability. Post-operative considerations. Tracheal obstructions after extubation may be related to post-operative edema or surgical complications. Continued reduction to ventrodorsal movements may worsen by over-sedation and poor pain control. Consider the epidural catheter for management of post-operative pain. Now we come to the end of this lecture by summarizing anterior mediastinal mass. General considerations. Patients with anterior mediastinal mass are at risk for airway and cardiovascular compromise with general anesthesia. Preoperative considerations. Careful preoperative evaluation include the history, physical and imaging. Consider whether the general anesthesia is absolutely necessary at this time. Can this procedure be done under local or regional anesthesia? Can an alternate node be biopsied? Can the patient proceed to radiation prior to operation intervention? Intraoperative considerations. Potential for cardiovascular collapse on induction of general anesthesia. Avoid the muscle relaxants. These are the intraoperative considerations. Postoperative considerations. Continue to monitor the patient closely during the postoperative period for signs of airway or cardiovascular compromise. Thank you.